I think a really great question. The key thing here is that, for example, ESMO to have this sort of a session as a rare GU cancer is a great sort of an initiative. And we really need to build on that. We really need to talk about these patients who are, I have called that as an area of unmet need, and I call variant histology of bladder cancer as an orphan disease. And I think having these sort of initiatives, talking about that at ESMO, ASCO, and big global meetings where global colleagues from all around the world come over, it is important to look at that and basically design a study which is relevant for all patients and across the globe. And that is what we want to do. But again, having these sort of events, having these sort of initiatives help. Again, Andrea Naki and other colleagues are also working. We're all working together to try and set up these sort of things where we can discuss what should be the trial design and how we can include more and more patients in the trial. But having this sort of a coverage within the ESMO does play a big role. I think in metastatic bladder cancers, for example, we know about EV302 data, but this is for urothelial cancers mainly patients, and that has changed 16 months versus 32 months. A few years ago, we saw Javelin 100 with maintenance avelumab, which again showed significant survival benefit with maintenance avelumab against best supportive care, 15 months versus 23.8 months from the start of randomization into maintenance avelumab versus best supportive care. I talked about in my talk that actually in the last 10 years in urothelial cancer, we have moved. Median survival has moved from 15, 16 months. We are moving into 30 months and more. We are seeing more and more, small percentage, 30% patients who are with us 3 years and further down the line. And these are important figures that, median survival has moved to 30 months plus, and the number of patients who are alive at 2 years and 3 years are significantly increasing. And that was only possible because we did large clinical trials together as a global GU community, and we answered those questions. And today, really, the key thing is to start thinking and focusing on this variant histology of bladder cancer, which is a small subtypes. And as I said, many clinical trials excluded them from the main study because they had sort of a rare variant histologies in that as well. Later on, it only predominant sort of variant histologies which were not part of the trial, but a small proportion of sort of a variant histology was allowed. But again, that starts to become very debatable. Is it 10% or 20% that will be included or excluded? So I think now is the time really to focus on these variant histologies, which are predominantly variant histology. They remain a small percentage of patients, 15% of patients for all bladder cancer. But again, we need to not forget them and start clinical trials focusing on those groups of patients to improve the outcome for them.